Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 244 of our pharmacotherapy series, which majors in infectious diarrhea. The first question reads, B.M.K is a 78-year-old man presenting to his physician with a diarrheal illness for one day. His illness began with vomiting and was followed by abdominal pain, nausea, and watery, but non-bloody, diarrhea. Despite not feeling well, he is able to drink fruit juices. B.M.K's history of present illness is significant for eating raw oysters at a local seafood restaurant 2 days ago, and he has since learned that other patrons are experiencing a similar illness. B.M.K has no significant medical history. He denies recent hospitalization, contact with small children, recent travel, or recent use of antimicrobials. On physical examination, B.M.K is alert and oriented, is not toxic, appearing, afebrile, and has stable vital signs. The remainder of his examination is significant for decreased skin turgor and dry mucous membranes. So my question to you is, what is your general approach to the management of B.M.K's diarrheal illness? Because infectious diarrhea is typically a self-limiting illness, patients may never seek medical attention, and in many cases, replacement of fluids and electrolytes is all that is required. In general, medical evaluation is warranted for patients with profuse watery diarrhea with dehydration, bloody stools, temperature greater than 101.3 degrees Fahrenheit, or illness of more than 48 hours duration. Other persons requiring medical evaluation include patients older than 50 years of age with severe abdominal pain and immunocompromised patients, e.g., those with acquired immunodeficiency syndrome, organ transplant recipients, or patients being treated with cancer chemotherapies. Non-infectious causes for the illness such as medications, inflammatory bowel disease, consumption of poorly absorbable carbohydrates, e.g., sugarless candies or chewing gum, or malabsorption syndromes should be considered. The next question reads, what rehydration plan would you recommend for B.M.K? B.M.K's physical examination is significant for decreased skin turgor and dry mucous membranes, findings consistent with mild to moderate volume depletion. Given that B.M.K is not toxic, appearing, with stable vital signs, and is tolerating oral liquids, oral beverages containing glucose, e.g., lemonades, sweet sodas, or fruit juices, or soups rich in electrolytes are appropriate. In developing countries, significant reductions in dehydration-related mortality is attributed to oral replacement therapy solutions containing optimal concentrations of sodium, potassium, chloride, bicarbonate, and glucose. The glucose content of these solutions is responsible for accelerating the absorption of sodium. Intravenous replacement therapy is warranted for severe dehydration, characterized by lethargy, very sunken and dry eyes, a very dry tongue and mouth, a pulse that is fast, weak or non-palpable, poor urine output, and low blood pressure, or for persons with intestinal ileus or who are unable to drink on their own. The next question reads, how does B.M.K's clinical presentation as a non-inflammatory versus inflammatory diarrheal illness help to guide further treatment? The clinical presentation, e.g., the specific symptoms, the severity and duration of symptoms, along with the history of present illness, e.g., risk factors for infection, allows for classification of diarrheal syndromes as non-inflammatory versus inflammatory illnesses. Such a classification allows the physician to consider a more focused list of potential enteropathogen or enteropathogens, and based on the list of suspected organisms, a diagnostic and therapeutic plan can be developed. B.M.K's history of present illness and clinical presentation are consistent with a non-inflammatory diarrheal illness. Voluminous, watery, non-bloody diarrhea is characteristic of pathogens targeting the small bowel, which is responsible for absorption of most fluids entering the GI tract. The clinical manifestations of non-inflammatory, watery diarrheal illnesses are a consequence of bacterial enterotoxins that promote the secretion of water and electrolytes into the intestinal lumen, or of viruses infecting and damaging the absorptive villus tips, resulting in voluminous watery diarrhea. Like B.M.K, patients with non-inflammatory diarrheal illnesses are not severely ill, are afebrile and without significant abdominal pain. Most patients require only supportive therapies. Non-inflammatory diarrheas are typically caused by viruses, e.g., rotaviruses and noroviruses, bacteria, e.g., Staphylococcus aureus, Bacillus cereus, and Clostridium perfringens, or parasites, e.g., Cryptosporidium parvum and Giardia lamblia. In contrast, inflammatory diarrheas are generally a more severe illness characterized by diarrhea with or without dysentery, abdominal pain, and fever. Pathogens targeting the distal small bowel and colon disrupt the epithelial barrier, causing the bloody or mucoid stools. In addition to supportive therapies, selected persons with inflammatory diarrheal illnesses may benefit from antimicrobial therapy directed at the causative pathogen. The clinical manifestations of inflammatory diarrheal illnesses are a consequence of the production of cytotoxins, e.g., as produced by Clostridioides difficile, Shiga toxin-producing Escherichia coli, and entero-aggregative Escherichia coli, or of the pathogen's ability to invade the intestinal mucosa, e.g., Campylobacter jejuni, Shigella species, and Salmonella species. The next question reads, B.M.K's stool is negative for WBCs and RBCs. With B.M.K's history of dining at the same restaurant as other patrons having a similar illness, the physician calls the Ministry of Health to find out if similar illnesses are being reported throughout the city. The physician is informed that an outbreak of norovirus, previously called Norwalk-like virus gastroenteritis, was confirmed at the restaurant where B.M.K had dined. Why is B.M.K's history of present illness and clinical presentation consistent with the presumptive diagnosis of a viral gastroenteritis, specifically the norovirus? What supportive therapies are recommended? Noroviruses are responsible for major outbreaks of foodborne viral illnesses in both adults and children, usually in association with restaurants, schools, and day-care centers. The virus is spread by eating inadequately cooked clams and oysters harvested from contaminated waters and other contaminated foods, e.g. salads, and sandwiches, by person-to-person contact, or by exposure to contaminated recreational waters. Like B.M.K, within 12 to 48 hours after exposure to the virus, patients complain of nausea, vomiting, diarrhea, and abdominal cramps. B.M.K will likely experience a mild intestinal illness lasting 1 to 3 days. Supportive therapies to correct fluid and electrolyte losses and to replace ongoing losses are the mainstay of treatment for viral gastroenteritis. Preventing future outbreaks will require the restaurant to ensure proper food handling practices. Other common causes of viral gastroenteritis are rotaviruses and astroviruses, which are responsible for 30% to 60% of all cases of severe, watery diarrhea in children. After an incubation period of 1 to 3 days, patients experience fever, vomiting, and non-bloody, watery diarrhea. Otherwise healthy persons are typically ill for 5 to 7 days. In the United States, 2 oral rotavirus vaccines are available for the prevention of rotavirus gastroenteritis in infants and children, a pentavalent 3-dose series and a monovalent 2-dose series. Vaccine effectiveness in high and upper middle income countries ranges from 79% to 100%, with the benefit of vaccination outweighing vaccine risks, e.g., intussusception when a part of the intestine folds into another adjacent part of the intestine, referred to as telescoping, which can lead to intestinal obstruction. As rotaviruses are spread by the fecal-oral route, proper hand washing and disposal of contaminated items are essential to limit the spread of infection. The next question reads, M.T.M is a 50-year-old man hospitalized for severe watery diarrhea, vomiting, muscle cramping with weakness, and confusion, notably unable to recognize his family members. His history of present illness is significant for returning 1 day ago from Haiti, where he visited with relatives, several of whom were recovering from diarrheal illnesses caused by Vibrio cholerae. Approximately 24 hours before admission, he noted the onset of watery diarrhea and immediately began drinking the oral rehydrating solution remaining from his trip to Haiti. However, over the past several hours he has been unable to drink on his own, and his family noticed white flecks in his stools. M.T.M lives in Florida, and his past medical history is significant for peptic ulcer disease, for which he takes a proton pump inhibitor. In the emergency department, M.T.M's vital signs are as follows: afebrile, blood pressure is 70 systolic 40 diastolic, and heart rate is 130 beats per minute. Physical examination reveals a severely ill-appearing man with altered mental status, sunken eyes, poor skin turgor, and dry mucous membranes. The physician's assessment is severe dehydration because of massive diarrhea, most likely caused by Vibrio cholerae. So my question to you is, what are his risk factors for cholera and why is his clinical presentation consistent with this diagnosis? We will first look at the risk factors. M.T.M has 2 risk factors to explain his presumed diagnosis of cholera. First, he has just returned from Haiti, a county suffering from epidemic cholera following a major earthquake in 2010 that severely damaged public health facilities. In developed countries, cholera has been virtually eliminated because of modern sewage and water treatment systems. However, sporadic cases, like M.T.M, occur in travelers returning from areas where cholera is epidemic or endemic, or from the consumption of contaminated and undercooked seafood, e.g., improperly preserved fish, raw oysters, and shellfish, from waters off the Gulf Coast states or imported from endemic areas. Second, M.T.M's daily use of a proton pump inhibitor reduces his stomach's acidity, thus allowing the acid-susceptible Vibrio cholerae to pass from the stomach into the small intestine. Regarding the clinical presentation, cholera epidemics are caused by toxin-producing strains of Vibrio cholerae 01 or 0139. The characteristic voluminous, watery, and colorless stools with white flecks of mucus, which is referred to as rice water stools because of their similarity to the appearance of water after washing rice, are caused by the cholera toxin, which promotes the intestinal secretion of fluids and electrolytes. The severity of cholera and likelihood of infection is influenced by host factors and the setting in which it occurs. Severe disease is more common in previously unexposed persons like M.T.M who are immunologically naive, e.g. epidemic cholera, while less severe disease occurs in areas where cholera is endemic. Following ingestion of contaminated foods, a watery diarrheal illness begins within 12 hours to 5 days and may progress to life-threatening dehydration. The next question reads, what are the signs and symptoms suggesting M.T.M is severely dehydrated, and how should his dehydration be treated? M.T.M is one of the 2% to 5% of persons with Vibrio cholerae infection who experience severe dehydration, that is equal to or more than 10% dehydration, losing up to 1 liter per hour of fluid, and whose condition may, within hours, progress to hypovolemic shock and death. M.T.M shows signs of severe dehydration as manifested by his altered mental status, sunken eyes, poor skin turgor, dry mucous membranes, low blood pressure, and increased heart rate. Acidosis may occur as a result of massive bicarbonate losses through diarrheal stools, and it may be exacerbated by lactic acidosis from shock and hypovolemic renal failure. M.T.M should receive vigorous IV hydration with Ringer's lactate solution to replace the large quantities of sodium, potassium, and bicarbonate lost through his watery stools. His muscle weakness could be attributed to depletion of electrolytes, specifically potassium and calcium. Monitoring of blood pressure and normalization of heart rate are critical interventions. Once M.T.M is able to drink fluids, oral hydration can be started, even with ongoing IV hydration. Oral replacement solutions containing less than 75 milliequivalents per liter of sodium are inappropriate because of the large amounts of sodium lost through cholera stools. Oral rehydration solutions can be made by mixing together 1/2 teaspoon salt, 6 teaspoons sugar and 1 liter of safe water. The next question reads, would M.T.M benefit from the administration of antimicrobials, and what antimicrobial treatment options are available? Antimicrobials are recommended for patients with moderate to severe dehydration from cholera infection. Effective antimicrobial therapy decreases the volume of diarrheal losses, shortens the duration of illness by up to 50% and reduces the period of shedding infectious organisms from longer than 5 days to 1 to 2 days. Antimicrobials should be administered after the initial fluid deficit has been corrected and, if applicable, after vomiting has resolved. Regarding antimicrobials, if susceptible, the following single and multiple dose regimens are effective treatments for Vibrio cholerae. Single dose regimens are preferred because of their ease of administration, and compared to multiple doses of erythromycin, they are better tolerated. Among adults, we can treat using doxycycline 300 mg orally as a single dose, or azithromycin 1 gram orally as a single dose, or ciprofloxacin 500 mg orally twice a day for 3 days, or tetracycline 500 mg orally every 6 hours for 3 days, or erythromycin 250 mg orally 4 times daily for 3 days. TMPSMX resistance precludes its empiric use for the treatment of cholera. Among children, we can treat using ciprofloxacin dosed at 15 mg per kilogram per dose orally twice a day for 3 days, or azithromycin 20 mg per kilogram orally as a single dose, or erythromycin dosed at 12.5 mg per kilogram per dose orally every 6 hours for 3 days. Remember, pediatric doses should not exceed maximum adult doses. For M.T.M, a single 300 mg oral dose of doxycycline is a good empiric choice, as the strain of Vibrio cholerae circulating in Haiti is currently susceptible to tetracycline, indicative of susceptibility to doxycycline. Empiric ciprofloxacin is not recommended because the circulating strain in Haiti has reduced susceptibility to ciprofloxacin, which is associated with lack of clinical and microbiologic improvement. Additionally, until M.T.M has recovered from this cholera infection, he should refrain from taking his proton pump inhibitor, which, by reducing his stomach's acidity, allows the acid-susceptible Vibrio cholerae to pass from the stomach into the small intestine. The next question reads, CUT is a 45-year-old man presenting to his physician with 1 day of non-bloody, watery diarrhea. 2 days before his illness, he ate a meal of raw oysters at a restaurant specializing in fresh local seafood. CUT lives along the coast of Florida and has no significant medical history. His physical examination reveals no evidence of dehydration. So my question to you is, why is CUT's history of present illness and clinical presentation consistent with non-cholera Vibrio gastroenteritis? A key piece of information from CUT's history of present illness consistent with the presumptive diagnosis of non-cholera Vibrio gastroenteritis is consumption of raw oysters harvested from the coastal areas of Florida, where Vibrio parahemolyticus species have been identified. Diarrhea, abdominal cramps, nausea, vomiting, and fever begin after a median incubation period of 17 hours. That range is 4 to 90 hours. Bloody diarrhea occurs in 9% to 29% of cases. The next question reads, should a course of antibiotics be prescribed for CUT? In otherwise healthy adults like CUT, Vibrio parahemolyticus gastroenteritis is usually a mild, self-limiting illness lasting for a median of 2 to 6 days. There are no data to support the benefit of antibiotics in this setting, although patients with diarrhea lasting longer than 5 days may benefit from treatment with tetracycline or a fluoroquinolone, minocycline 100 mg orally every 12 hours and cefotaxime 2 grams IV every 8 hours have also been recommended. Individuals with liver disease or alcoholism are at risk for severe Vibrio infections including septicemia. Such individuals should avoid eating raw or undercooked shellfish, and avoid exposure of open wounds to seawater, especially during the warmer months when water temperatures favor the growth of Vibrio species. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 245.